Oh, hi, Appy. We bumped into each other again.
Who knows who's behind it?
What are you up to in our library?
Trying to figure out pancreatitis.
I have got it sorted. Let me help you.
Hi guys, today we'll discuss the topic of chronic pancreatitis. So, starting with the etiology of chronic pancreatitis, it is remembered with the mnemonic TIGAR-O, where T stands for toxins such as alcohol, I is idiopathic like cystic fibrosis, G stands for genetic factors, A is autoimmune pancreatitis, R is recurrent acute pancreatitis, whereas O stands for obstructive conditions like cholelithiasis or a pancreatic head mass. Now that we have understood the etiology of chronic pancreatitis, we look at the imaging features. So this is a case scenario where we can see that there is atrophy of the surrounding pancreatic parenchyma. The most important feature of chronic pancreatitis being there is an irregularly dilated duct. So we can see that it is very irregularly dilated pancreatic duct. You can see there are intraductal calcifications, whereas you can also see there are intrapancreatic calcifications. So intraductal intrapancreatic calcifications, irregularly dilated duct, which is the most important feature of chronic pancreatitis. Along with that, you will see atrophy of the pancreatic parenchyma. Now that we have understood the imaging findings, we'll see what are the differences between chronic pancreatitis and main duct IPMN. What is IPMN? Intraductal papillary mucinous neoplasm of the pancreas. We'll start with a case scenario. So, this is an example of chronic pancreatitis. This is an example of main duct IPMN. So, in this case, we can see that the duct is irregularly dilated, whereas in IPMN, the duct is smoothly dilated. Moving forward, we'll be discussing the difference between chronic pancreatitis and main duct IPMN. What is IPMN? IPMN is intraductal papillary mucinous neoplasm of the pancreas. Now, any smoothly dilated pancreatic duct measuring more than 2 centimeters is considered a main duct IPMN unless proven otherwise. Now we'll move forward to look between the differences between chronic pancreatitis and a main duct IPMN. As we have discussed, the duct will be irregularly dilated in chronic pancreatitis. It is smoothly dilated in IPMN. We already know calcifications are a major feature of chronic pancreatitis. It may or may not be present in main duct IPMN. The other two associated features are atrophy of the pancreatic parenchyma is an early feature in chronic pancreatitis. However, it is a late feature in IPMN. Presence of a mural nodule. It may or may not be present in IPMN, but it is never ever present in a chronic pancreatitis. Right? Now we are done with chronic pancreatitis. Now we'll move towards autoimmune pancreatitis. Autoimmune pancreatitis is a repeatedly asked long case in our vivas, right? Autoimmune pancreatitis, there are three types of autoimmune pancreatitis. Type 1 being lymphoplasmacytic sclerosing pancreatitis. Type 2, which is idiopathic duct-centric chronic pancreatitis. Type 3 is a new one, that is drug-induced chronic pancreatitis. The imaging features remain the same. Now we'll move forward to imaging features. So, this is the CT of an autoimmune pancreatitis where you can see a bulky pancreas with loss of lobulations. Along with it, this appearance is called as a sausage shaped pancreas, right? Which you go ahead and do an MR. On MR, you will see this T2 hypointense rim, which will show a delayed gradual progressive enhancement, right? So now that you understood, the imaging features are same between type 1 and type 2 autoimmune pancreatitis. So how do you differentiate them? So you will differentiate them based on the clinical history as well as the biochemical markers. Clinical history being an elderly patient is coming to you, then think of a type 1 autoimmune pancreatitis. However, in a young patient, you most likely see a type 2 autoimmune pancreatitis. The others being levels of serum IgG. IgG4 levels are elevated in type 1. They are normal or slightly elevated in type 2 autoimmune pancreatitis. On histopath, if you're seeing an Ig4 infiltration of the pancreatic parenchyma, it is most likely type 1 and you would not see infiltration in type 2. Coming to extra pancreatic complications like IgG4 induced cholangitis, iotitis, retroperitoneal fibrosis, renal lesions. There are various other lesions. We'll discuss about IgG4 in a different video. So if you're seeing any of these extra pancreatic complications, it is most likely type 1. If you're not seeing any extra pancreatic complications, it is most likely a type 2 autoimmune pancreatitis. Now that we are done with autoimmune pancreatitis also, we'll move towards one of the most commonly asked spotter, that is groove pancreatitis. Groove pancreatitis is a condition where there is ectopic pancreatic tissue in the pancreaticoduodenal groove. Because of this, because of the ectopic pancreatic tissue, sorry, not in the duodenal groove, you will see in the medial wall of the duodenum, which will lead to fibrosis in the pancreaticoduodenal groove. Because of this fibrosis, on CT, you will see an ill-defined area of hypodensity in the pancreaticoduodenal groove, as we can see in this case scenario. Because it is a fibrotic tissue, you will see a delayed, gradually progressive enhancement on post-contrast images. So coming to T2 weighted MR, in T2 weighted MR, you will see that there are few cysts in the medial wall of the duodenum. So typically they'll show a CT and a spotter where you will see some amount of fibrosis in the pancreaticoduodenal groove. Finally, coming to a few other spotters, fatty replacement of the pancreas. We know it can be seen in chronic pancreatitis, but if it is a child coming to you with fatty replacement of the pancreas, think about cystic fibrosis or Schwarzman-Diamond disease. Bullseye appearance of calcification in a child, where do you see is hereditary pancreatitis. Hereditary pancreatitis can in turn lead to chronic pancreatitis. Now we are done with chronic pancreatitis and various forms of chronic pancreatitis. If you do like our simplified version of analyzing radiological topics, please leave a comment in the comment box. And if you guys have any queries, as well as you guys want us to take some other topic which you guys are finding it difficult, please leave a comment below. Thank you.
Looks like you had great knowledge about pancreatitis.
Everyone has their favorites.
Am I one among them?
That's a question to answer later.
Hey guys! If you like our simplified approach to difficult conceptual topics, please do comment, like, share, and subscribe to our channel.